Good evening, everyone. I'll be describing two of the cases which I had seen, and then I'll be summarizing the other three which were discussed previously. So, the first case was a 7-year-old child, female child, who presented with decreased vision in one eye, gave a 1 week history. The history was not very clear. The parents gave a history of injury with some foreign object. The exact nature of the object, the child couldn't tell. She had pain, redness in her left eye, which started 2 days after the injury. The best corrected visual acuity of the right eye was 6.6, of the left eye was hand movements. This was the picture which we saw at presentation. The right eye was normal. The left eye, there was an entry wound at the limbus. We could see retrolental vitreous exudates on slit lamp examination. The ultrasound was done. There were vitreous echoes. In the inferior quadrant, there was a suspicion of PVD, and there were some dense vitreous echoes inferiorly. On examination under anesthesia, we got a more clear idea. She had an entry wound at the limbus with an iris hole with it, with a vitreous prolapse, and there were retrolental exudates as well. We decided to proceed with the right eye lensectomy with vitrectomy on the same day. She underwent lensectomy, vitrectomy with injection vancomycin, ceftazidime, and voriconazole at the end of the surgery. In this surgery, PVD was induced. Intraoperative, there were organized exudates in the vitreous cavity, as well as a few exudates on the retinal surface. The anterior, while the lensectomy was being done, the anterior capsule of the lens was retained. She was also started on intravenous antibiotics, intravenous ceftazidime with topical steroids and antibiotics. On the first post-op day, we saw that the PCR was positive for Eubacterium. The gram stain was showing some gram variable pleomorphic bacilli. This was the post-op day 2. There was some vitreous haze. First order vessels were seen. Some vitreous retinal exudates and vitreous exudates inferiorly. The ultrasound showed a few mobile vitreous echoes in the wet cavity, and the retina appeared attached. So we decided to give an injection of ANCO with ceftazidime with dexamethasone. This was the fourth post-op day. The vitreous cavity was relatively clear, better compared to the previous. The OCT scan, sorry. There were some vitreous retinal exudates which can be hazily seen inferiorly, and some vitreous inferior vitreous exudates can be seen, and these are the retinal and few subretinal exudates.
No, they are pre-retinal. Okay.
Yeah,
Nothing is subretinal.
Pre-retinal. An OCT was done, which was grossly there was minimal retinal edema. Otherwise, this was the post-op day 9. Similar to Purna's case, even here the culture came positive for abiotropica. It was sensitive to all the antibiotics: ciprofloxacin, clindamycin, gentamicin, moxi, penicillin, and tobramycin. So later on, she was discharged, shifted on to moxifloxacin eye drops with tapering topical and oral steroids. As we can see from the previous, the retinal pre-retinal exudates are decreasing. Even the vitreous exudates had reduced. She later came for glass appointment. The retinal exudates were resolved. The vitreous exudates are also resolved. We had saved the anterior capsule. Her phakic correction was 6.9 with plus 15 diopters. This was her recent visit. She is doing pretty well compared to the last. The next case was a 22-year-old male. He came with an injury with the iron rod. This was just a one-day history. He visited a local hospital. No primary management had been done as such. His best corrected visual acuity was hand movements in that eye. There was a full thickness corneoscleral tear with hypopyon. The AC was shallow. There was some fibrin in AC also. And there was no lens breach which could be seen on the slit lamp. sorry for the pictures. These were taken in the emergency on my phone. There was a hypopyon which can be seen in both the pictures. The corneal tear can't be seen here, but there was a superior corneal tear which can be vaguely made out on that. The we try to do a gentle B scan just to know the status of the vitreous. Also, if there was any suspicion of if there was any foreign body, but there was just minimal vitreous echoes. He underwent a corneoscleral tear repair with an intravitreal injection of Vancomycin septa at the conclusion of the surgery. The anterior chamber sample was taken, and also the excised iris tissue was sent for microbiological evaluation. In during the surgery, we tried to see the retina after the tear repair, but because of the extensive injury, the view of the retina wasn't there. So at the end of the surgery, a prophylactic antibiotic was given. This was the intra-op picture. On supine position, the hypopyon had actually dispersed. The nasal extent of the tear went to around 5 mm into the sclera. The temporal extent was around 2 mm. On the first post-op day one, he again had hypopyon in the anterior chamber. There was some dispersed heme and some fibrin over the lens. The view of the posterior segment was still not very clear. On ultrasound, there were some vitreous echoes which could be seen. There was a high reflective membranous echo in the superior nasal and the nasal quadrant. So there was suspicion of traction. A repeat intravitreal injection of vancomycin with deca was given at this point of time. On the third post-op day, again there was no view of the posterior segment, but the fibrinous exudate in the AC had started to contract. The anterior chamber reaction was decreasing. The wound was well opposed. His pressure was building up. This was the ultrasound. We can see that the verticos were started to organize. The suspicious traction in the nasal quadrant and the superior nasal quadrant was still present. On the fourth post-op day, the vitreous, the AC membranes, the AC fibrin had cleared more than previously. So the anterior chamber was also formed. At this point of time, we could see retrolental opacified vitreous, and still there was no growth noted in the AC sample and the iris tissue sample which was sent previously. So this patient was at this point of time planned for lensectomy and vitrectomy. He underwent lensectomy with vitrectomy. In this case, PVD was not induced. A core vitrectomy was done for debulking. Intra-op with biopsy was sent, and at that point of time, gram-negative bacilli was seen. At the end of this surgery, again, intravitreal antibiotic was given. This was on the second post-op day after the vitrectomy. There was suspicious traction in the nasal quadrant. Also, there was some opacified vitreous. Then again, a repeat injection was decided to be given. On the seventh post-op day, the picture was much better. The PVD had been induced, and there was opacified vitreous, some clot which was seen nasally, and so he was planned for a revitrectomy after some days. So he underwent revitrectomy. Now the retina was seen clearly. There was some retinal hemorrhages, sclerosed vessels, some organized exudates which were present on the retinal surface on the posterior pole, which were dispersed using the flute needle at that point of time and were removed to the extent possible. This was post-op day 5, status post the last surgery. The corneal tear was well opposed. The AC anterior chamber was formed. There was no AC reaction. This was the fundus picture. There was very minimal vitreous haze. The retina was attached. Few subretinal exudates can be seen superior to the disc near the superior temporal arcade. This was my second case. I'll just summarize a few points in relation to this topic, and then I'll summarize all the 5 cases. So post-traumatic end-off is different from post-surgical end-off, which we usually see because there is a trauma-induced inflammation. Also, there is a disruption of the ocular structures. The clinical signs of suspected infection in cases of these injuries are firstly a purulent exudate at the site of the injury, any eyelid edema, chemosis, corneal edema, hypopyon, signs of severe anterior chamber inflammation, vitritis or vitreous opacification. If there is not much of vitritis or opaque vitreous, then retinitis or periphlebitis should give a suspicion of infection. Patients coming with extreme pain and hypopyon with vitritis usually should be thought of the thought of an infection should come first. Then there are patients with present with hypopyon, but we need to know which are infective and which are inflammatory. So such patients should be followed up closely in case there is an inflammation and we're treating with steroids. And it is resolving, that means that it is an inflammatory hypopyon, but still they should be kept. We need to see for other signs of infection in such cases. AC sample, an AC tab can be taken and sent in such cases. Now there are in traumatic endophs, as we saw in these 5 cases, culture. There were just 2 patients which are culture positive. The other ones were culture negative. So even if it is culture independent, we can clinically diagnose it as endophthalmitis. As the literature also says that culture independent post-traumatic endophs are almost comparable to the ones which are culture positive. Role of ultrasound at presentation, mainly it is for if we are suspecting any intraocular foreign body. Otherwise, always the primary repair should be done first. After the primary repair is done, then we can keep the patient, we can keep doing serial ultrasounds to see if the vitreous echoes, if we are treating with intravitreal injection, the vitreous echoes are increasing or decreasing, the PVD status of the patient, if the patient is developing any traction. The ultrasound helps us in this manner. But the goal of the primary management and the treatment is not always dependent on what the ultrasound shows. We need to see the patient clinically as well. Lens rupture, presence of lens breach is to diagnose presence of lens breach is important. It gives the bacteria direct access to the vitreous cavity, affects the normal flow of the aqueous humor, decreases. So that is why the clearance of the microorganisms are also decreased. During the primary surgery, in such cases, lens aspiration or lensectomy with good anterior vitrectomy should be done to the extent possible. So according to the risk factors of endophthalmitis in a penetrating trauma, first is the retained intraocular foreign body and presence of any lens rupture, delayed primary repair, a very large wound, a location of wound like zone 2 or zone 3 extending into the sclera, any ocular tissue prolapse, and injury which has taken place in a rural locality. This is one article, this is one study which was done in 2003 regarding the factors. They gave us a few factors which if present, we can think of giving prophylactic intravitreal antibiotic at the time of primary repair. In case we don't have definite signs of endophthalmitis. So in case there is a retinal periphlebitis, if there is a purulence around the foreign body, if it is a soil related injury or a very delayed, or we are doing a very delayed primary closure, we can think of giving prophylactic intravitreal antibiotics at the end of the surgery. Vitrectomy for endophthalmitis per se should be done mainly safely to debulk the inoculum. Inflamed retina can be fragile and prone to tear. So induction of PVD is very subjective. In case the exudates are limited to the anterior vitreous cavity, relatively limited retinal edema, and if we can see the retina in such cases, PVD still can be induced. Otherwise, it is not necessary always. A limited and partial vitrectomy can be done, and after the PVD is induced, to remove the opacified vitreous, and optical vitrectomy can always be done. During the primary surgery or the vitrectomy, any attempt to peel membrane should be usually avoided, as the retina is very inflamed in such cases. To summarize again the same 4 or 5 things, duration since the injury, setting of the injury, suspicion of any foreign body, presence of lens breach, hypopyon, vitritis, and periphlebitis. So we'll see if all these points are present in the cases which we saw. This is the table. I'll just go one by one. So the first case, which it was a 9-year-old girl, which Purna presented. She presented after 10 days, so the duration of injury was more. It was a sealed corneal tear, but hypopyon was present. There was no lens rupture, no suspicion of antibody. There were anterior vitreous exudates. On the preoperative USG, we had vitreous echoes which were present. So these all, the duration since the injury and presence of hypopyon with vitreous exudates should raise a suspicion that this is a picture, this is looking like traumatic endoff. This was treated.
So what Dr. Pramod is saying is that a pencil tip is always considered as a source of infection. I mean, a source that is definitely a polymicrobial infection. So what you get hit by is also important. Yes. So that is the reason why you must have a very good documentation. History taking is most important there. Even if it takes you another 10 minutes, must ask the attendants about what was the mechanism of injury. Yes. Circumstances of injury is most important, and that has to be documented very clearly. Yes.
What you mean, urban or rural, we more or less know, but what you look at it, what does that mean is not like a pencil tip in urban area and pencil tip in rural area. It is basically what you look at, circumstances, material, like which object we have, vegetative matter, or metal or flying object, all those things that comes into play. Rural, more likely we have a soil contamination. I mean, more likely, but that's not just only word rural or urban. Look at what are the different other circumstances.
Go ahead.
The second case which Manpreet was talking about was a 19-year-old male. Again, the duration since the trauma was around 6 days. It was a sealed corneal tear. Hypopyon was present in this case. Pars plana exudates in this case were seen intraoperative. Vitreous echo seen on ultrasound. This patient, we did a corneal tear repair with an AC tap and ocular antibiotics on the same day. The third case was a 31-year-old male. In this patient, the injury, though was recent, there was a full thickness tear. There was no limbal involvement. Here, both hypopyon as well as lens rupture was present. Again, there were pars plana exudates which was seen. He had to be taken up for corneal tear repair with lens aspiration on the same day itself. And then later on, lens matter removal with vitrectomy was done. The patient which I spoke about, the first child, 7-year-old child, she had presented 7 days after the injury. The nature of the injury we did not know. There was a penetrating injury at the limbus. So again, it is not a pure corneal tear, it is a limbal tear which went through the zonules, suspecting. Hypopyon was absent at the presentation when she came to us, but seeing that it is 7 days since presentation, we never know. It might be present in the beginning, but we did not have any documentation of that. Anterior vitreous exudates were clearly seen. Retrolental exudates were seen. This was again taken up for lensectomy with vitrectomy and antiretroviral antibiotic. The last patient came again with a 1-day history of injury. He had a full thickness tear with this was an extensive injury. Her hypopyon was present. Vitreous exudates initially were not visualized. They were seen on post-op days 4. Initially, vitreous echoes were not much. So this patient basically at presentation, the only point he had was that he had a hypopyon. Otherwise, on close follow-up, we saw that he developed or he might be having endophthalmitis, but the signs were seen. So this patient, when kept on follow-up, we realized that he needs a vitrectomy. So vitrectomy in this case was done at a later date at day 6. Coincidentally, this organism came positive in both the cases which we saw. Otherwise, there was no growth on culture on the other cases. To summarize again, in children, we can see that the injury the patients have presented later. Then when there is a penetrating trauma or a sealed, this was like a pinpoint injury in both the children. The inoculum was directly into the vitreous. So the anterior chamber was relatively okay. There were no there was not much anterior chamber inflammation compared to the other patients who had a direct corneal injury. Only one case, her hypopyon was absent. As I said, she presented later. We never know, she might be having it before. In these cases, there was no intraocular foreign body, but in case there is an intraocular foreign body, the urgency to operate or the urgency to remove that foreign body becomes more. So we need to think in that way.
Yeah. So another thing, you are quite. I think you mentioned. Yeah, ultrasound is not necessary when the globe is open. If you look at the quality of ultrasound that you have done, it shows that the eyeball is really soft. There were sclerochoroidal folds there. So it is not necessary to do an ultrasound when you don't suspect a foreign body. It is not going to change the management. You have to close the wound primarily, and then you can serially follow up with the ultrasound. So ultrasound is not paramount. I think evaluation of the posterior segment or at the, when they first examine for trauma, when you're taking it for surgery, or interop is more important. As you have seen in all cases, if it does not, vitrectomy was not done, at least intravitreal injection was given. Something was done at the time of injury. So even if the surgeons who are operating, they're closing the primary wound, they can, after the cleaning up the anterior chamber, after, if the cornea is reasonably good enough for you to have a look at the fundus, must try to have a look at the fundus. Otherwise, you can always give a intravitreal injection. The standard intravitreal injection that we give is vancomycin, ceftazidime, and dexamethasone. If you suspect fungus, then you may probably not use dexamethasone and use voriconazole in addition to the other two. So giving an antibiotic at the time of repair is actually quite useful. They are quite safe, and it gives us another day that we can fight the battle. You know, those are the safest antibiotics that we know of. You're not giving any unusual antibiotics. I would like faculty to talk about any other. Yeah. So.
Dr. Chatan, Meena here.
Yeah, Meena.
So they explained the cases. So I just want to know from the fellows, did they find out what were the medications that the patients were using? So it's very important to know whether the patient is already on topical steroids. One of the points that I want to just highlight, you need to know what the patient is on, because your topical antibiotics or steroids are contraindicated in full thickness corneal tears. So that also adds to the source of infection.
Yeah, it was.
Did you get the point?
Yeah, it's an excellent point, and also, Meena, I would say that cases where these are sealed wounds, and when we give, it's a tendency to start steroids anyway, and it's a
Yes,
thing.
yes.
You not
It also
suspect.
subsides inflammation. You cannot. It also reduces the chance of finding the.
Yeah, so it suppresses the inflammation, and you tend to uh, reduce your index of suspicion, thinking that the inflammation is controlled, there is no infection, but actually the inoculum is definitely there. You're only suppressing the minute you start reducing the dosage of your steroids, and if the patient has not undergone any treatment, you will have a chronic case of endophthalmitis. Dr. Muna, you raise your hand, please, ma'am.
Nice cases that you all described. I just wanted to say, Chetan has also mentioned it, but Priyanka showed one case where, the vitreous cavity and the whole eyeball looks actually very messy, but it's actually just the scleral folds and shadowing due to hypopyon. So the choroid is thickened and you see those infoldings with lot of shadowing. So, and immediately post-operatively, you see that entire thing reversed. So when you just see that picture, there is no need to assume that things are very bad. It's just the scleral folds. And the first case on top in the table, when you had silicone oil inside the eye, previously we didn't have antibiotics with good ocular penetration. So we used to give half of water dose of the intravitreal antibiotic, whereas now you have antibiotics with good ocular penetration. So if you're using tamponade, you can either use oral or intravenous antibiotics, and they will work as well.
Yeah, we completely agree, ma'am. I think there is a role for the IV antibiotics, and especially in the uh, in the event of a trauma and so much of inflammation, I think IV antibiotics will add and potentiate. There was a thought before that if you have high concentration of this antibiotics, especially that covers gram-positive and gram-negative in the choroidal circulation, that retains the intraocularly given antibiotics in the eye, rather than the longevity of the or the effectivity of the intraocular antibiotic that you give, the vancomycin, that is a gram-positive, and the ceftazidime or cefuroxime you give for the gram-negative or the amikacin. So they remain in the eye for a longer time because of the high choroidal, the concentration of the antibiotics in the blood across the blood-brain barrier, that is blood-retinal barrier. So it remains in the eye. So it's actually a good idea to keep giving, even though the penetration may not be, very few antibiotics do penetrate very well when given IV. Like ciprofloxacin has a very good penetration. Voriconazole itself has got a very good penetration. It reaches good MIC levels when you give orally into the eye. But another point to be noticed is if you have a breach in the blood-retinal barrier, most antibiotics will reach in the eye. May not be reaching it at high doses, but for that you need to maintain high doses of IV antibiotics. You can't just give one dose and stop it. You need to give continuous IV antibiotics so that it reaches a steady state of high concentration and does allow the eye to reach MIC levels good enough if the medicine is effective against the organism.
See, I mean, you mentioned last again, the moment you have a breach in the globe, somewhere discontinuity, and you have hypopyon, just consider is as infective. No question of considering is like a non-infective and inflammatory and wait for conservative. There are certain reasons probably you cannot, not necessary every case has to be done as a like a vitrectomy. Looking at the inflammation, like how bad or significant amount of inflammation, exudation is there, you decide about, lens damage and lot of other factors you decide while taking for vitrectomy. But yes, whatever antibiotic therapy when you start, it has to be immediately, you have hypopyon and you breach and perforating injury, you consider it as infective. There's no question of non-infective, all those, word doesn't come there actually. And not necessary every time you are going to get a culture positivity. It's just again a quantum of organism, what you have in a sample, what you send. And best of the labs also, you don't have positivity more than 65%.
Very, very good cases. 2 points I want to focus on. One is that the repeat intravitreal injection which is given. So some of the cases received the repeat intravitreal injection the second post-op day. That means first day you operated, the second day you are given intravitreal. So I think probably this may not be necessary unless it's a very fulminant kind of an infection. Or if it is like a fungal infection, but a routine post-operative or routine even a traumatic endophthalmitis, if you have given intravitreal injection on the day of the surgery, you can fairly easily wait for about 24 to 48 hours easily to look for the effect of the intravitreal drugs. If you feel that the infection is still progressing and there is no effect, or by that time you get your culture report and you see that the sensitivity is different than what you have given, in that situation you can repeat the intravitreal injection. But many times even single intravitreal injection is more than enough to control the infection. And second thing is there are some situations where after trauma the patient has had say trauma with vegetative matter, there is a tendency to give injection of both antibiotic as well as antifungal as well as steroids. So one big cocktail of vancomycin, ceftazidime, amphotericin or voriconazole along with steroids is given. So I am not very sure about the the rationale of doing such a kind of a thing, because either you give antibiotic or you give antifungal, and if you're giving antifungal then don't give steroids. So giving everything together, I don't know. I would like to know from LG sir and PV sir whether this kind of a thing is agreeable.
In fact, I was thinking that for traumatic endophthalmitis, of course, there's always a room for controversy whether you should give steroid upfront along with antibiotic at the first instance, or should we wait for at least 24 hours for the antibiotic to have some effect before you pitch in your steroid intravitreally. So traumatic cases, we know that can be a mixture of organisms, not just one pure infection. Usually there is a mixed bag of infections. It can be gram-negative, gram-positive, clostridial, all kinds of things, anaerobic, anything can be there, especially when it's contaminated with soil and all that. So in general, unless it's a clean-cut wound where you're suspecting that it's not a badly contaminated wound, I would prefer to hold back steroid intravitreally for at least 24 hours. And you can always cover it with systemic steroids later because you don't want to inject again. Since if there is no obvious worsening of infection, next day onwards, you just want to treat with topical drops, you can add systemic steroids rather than intravitreal on the table, not even allowing the antibiotics 24 hours time to act on the bacteria. This is just a point for contention. I'm sure many people may object to that and say we will give steroids upfront because you're confident that your antibiotic is acting on the organism, which is not always true for a traumatic case. Then the same thing holds good. If it's fungus can become worse with steroids, bacteria also can become worse. It's not as if there's anything to choose between the two, except that most antibacterial antibiotics are more effective against bacteria than antifungal antibiotics are. That is the reason why you don't want to hasten the growth of the fungus while the drug is acting in a weak manner on the fungi. Not because steroids are anyway better suited for bacteria. Even for bacteria, ideally, if you wait for 24 hours, it's actually better. But where you're confident your drug is going to be effective, yes, you're justified in injecting the steroid along with it. So for traumatic cases, I would hold back steroid on the table. I would give it probably a day later. I think if you're strongly suspecting a vegetative matter, because nothing stops a mixed infection of fungus and bacteria being present with an injury. It's a different matter if you see a fungal endophthalmitis, bacteria cannot grow because fungi produce antibacterial agents, so they kill all the bacteria. It's very rare to see a fungal endophthalmitis with a bacterial endophthalmitis in the same eye. But a contaminating agent can have both fungi and bacteria together. So if you're sure it's a vegetative matter, you want to really protect against fungi, no harm in combining antifungal drug with antibacterial drug. But as I said, the number of such cases will be very few.
I have a question, sir. How to decide when to retain the capsule while doing lensectomy, vitrectomy in such traumatic endophthalmitis? Like, is it advisable to leave it, or if you want to leave it, when to leave the anti-capsule?
I don't think that should affect your management, because if you want to repeat intravitreal also, you can go through the limbus, through the capsule and inject in the vitreous cavity. You're not tearing the capsule, so its capsule is still intact for a secondary IOL if you want to. That's the intention of leaving the capsule, right? So I don't think that should be a problem at all, as long as you know the information is getting controlled. And it's not like a P. acne where it can act as a scaffold for retaining the bacteria. It's just a basic traumatic endophthalmitis. You can retain the capsule if you wish to. That's not a problem at all.
Only doubt here is sometimes because of inflammation is severe. If you have a significant amount of infection, subsequent fibrosis, scarring, and that iris and capsule gets stuck and then can develop thick membrane in a pupillary area, that can become things messy. So if you have a doubt, if you have things like a lot of inflammation, might as well do a clean job. Don't do any scaffold for like a fibrosis to occur. Because then with this fibrous polyp, then you can sometimes it turn into cyclitic membrane vessels growing on it and gross hypotony. Having a clean job, and we know we all are comfortable with SFIOL now. If things settle down, later on we can take. Yeah, but like a clean injury, just lens matter. You are not really worried about much. There's not much inflammation, but ensure that all lens matter, everything is done clean. Pupil remains mobile later on. That's a different issue.
Pseudophakic endophthalmitis. You sometimes remove the entire intraocular lens, leave it on the capsular bag, because you're not able to clear the media properly. The whole thing is cocooned. So the decision to leave the capsule is absolutely individualistic, based upon a particular eye. It's not a generic statement. So I absolutely agree with what Pramod said, that where you think it's not going to do well if you leave behind too much of material, you have to remove everything and clean up the whole of the fundus rather than retain lens matter just because you want to put IOL later on.
Okay, then thank you very much, Cornea team joining. And wonderful cases. Like, congratulations to all of you. Good job done.
Thank you, sir.